My name is Natalie Byers. I'm a student physical therapist assistant at Lake Washington Tech. My final presentation is called Huntington's disease. Don't judge a book by its cover. By the end of this presentation, you will be able to correctly identify 2 symptoms of Huntington's disease and be able to identify 2 interventions that are appropriate when working with patients with Huntington's disease. So what is Huntington's disease? Huntington's disease is a progressive genetic neurological disorder that causes degeneration and atrophy of the basal ganglia and cerebral cortex within the brain. The basal ganglia is important because it regulates initiation of movement, inhibition, and also plays a key role in learning, cognition, and emotion. Huntington's disease causes the neurotransmitters to become impaired and makes them unable to regulate movement. This causes symptoms such as chorea, which is involuntary jerking movements, and dystonia, which is involuntary muscle contractions that cause twisting movements, abnormal posture, and repetitive movements. Huntington's disease also causes impairments in cognition. Huntington's disease is usually diagnosed between the ages of 35 and 55 years old. Unfortunately, there is no cure for Huntington's disease, and it is fatal within 15 to 20 years after diagnosis, and because it incapacitates the patient both physically and mentally. This next slide is the ICF model for the patient that I worked with in my second clinical rotation, who I'm going to call Cindy Lopper. Cindy is a 45-year-old woman who was recently diagnosed with Huntington's disease. Overall, Cindy is independent with her activities of daily living, but she does use a 4-wheeled walker for community distances to help with her fatigue. She loves her Jeep, she loves the Seahawks, and she loves rock and roll music. She presents with chorea, dystonia, difficulty speaking, difficulty processing information, and generalized muscle weakness. Unfortunately, Cindy does not have a permanent living situation, and she tends to couch surf between friends' houses, and she also does not have a very good support system, which is unfortunate and difficult for someone who has a progressive disease such as Huntington's. Cindy originally went to her doctor because she was having left knee pain. She had previously had a left ACL repair back in 2011. The doctor performed a bunch of special tests such as the McMurray anterior posterior drawer, LCL, MCL laxity test, but they were all negative. Because she does have Huntington's disease, the doctor recommended that we address her left knee pain as well as the symptoms associated with Huntington's disease. Physical therapy was appropriate due to Cindy's decreased balance, decreased endurance, decreased motor control, and the need for proper assistive device training. There were no contraindications for physical therapy with Cindy, but it was noted by the physical therapist in the initial evaluation that Cindy is a high fall risk. The plan of care was for Cindy to come 2 times a week for 8 weeks for a total of 16 visits, and then to have be reevaluated or progress note after that time. The short-term goals set by the physical therapist were to progress functional, motor control, and endurance, and progress Cindy's core strength and balance. The long-term goals were to instruct Cindy on safe usage of assistive devices and educate her on Huntington's disease, how the disease progresses, and what resources are available to her. The goals that Cindy had told us for physical therapy were to decrease her left knee pain and to help her maintain as much functional independence as possible with this progressive disease. The 3 interventions that were implemented into Cindy's plan of care were the LSBT Big, which we learned about with Claire, 4-wheel walker training, and therapeutic exercises such as chair push-ups, wood chops, and sit-to-stands. So why these interventions? Although LSBT Big was originally designed for patients with Parkinson's disease, it also may benefit individuals with other neurological motor disorders such as Huntington's disease. LSBT Big trains individuals to use big, purposeful movements to promote more normal movements because because the patient's movements tend to get slower and smaller as the disease progresses. LSBT Big can improve gait speed, stride length, arm swing, balance, and trunk rotation. So I'm going to go over some of the LSBT Big sequences and exercises that I worked with Cindy. The first 2 are done and seated, so all you need is a chair. So remember, big movements. So the first one, I want you to push forward, down, up, and out to the side. And we're going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And slap. And we would do that 10 times, but we're not going to do this right now. The next one is helping with trunk rotation. So in seated, you're going to twist to the side, arms out wide, legs out wide, and we're going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Back to center, slap. And then in the other direction. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Back to center, slap. Those are the 2 exercises that I worked with Cindy in seated. The other ones are all done in standing, so you don't need any equipment. Just make sure you have a big space because patients with Huntington's disease tend to be at a high fall risk. So the next one is going to be pushing forward, stepping forward, back, slap. And next, pushing forward, stepping forward, slap, and back. 2, 3, 4. The next one is going to be stepping out to the side. So I'm going to take a step to the left, arms up big. 1, 2, 3, 4. And we do that to 10. The next one is going to be stepping backwards. So arms up high, stepping back. 1, 2, 3, 4. The next one is going to help to increase arm swing. So it's a rocking motion back and forth. So just pick one leg forward and you're going to go arms forward. 1, 2, 3, 4. We're always counting. We would go to 10. Next, bring the other leg forward. Arms swinging. 1, 2, 3, 4 all the way to 10. And then the last one that we did, similar to the last exercise done in seated, but we're gonna do it in standing. So you're gonna turn and twist. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Back to center, slap. To the other side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Back to the center. We would do that 10 times. With Cindy, we did these, the LSVT big at the beginning because we wanted to help optimize her potential, since the LSVT big does promote bigger movements. Okay. So the next intervention that we worked on was four-wheeled walker training. So since Cindy already had a four-wheel walker, we wanted to use that because she already has it available to her. In a study that I found done by Cluse et al. Called The Impact of Different Types of Assistive Devices on Gait Measures and Safety in Huntington's Disease, examined the effectiveness of no assistive devices versus 6 different assistive devices. And those 6 assistive devices were a single point cane, weighted cane, standard walker, front wheel walker, 3-wheel walker, and a 4-wheeled walker. And it measured, we looked at gait, they looked at gait in a straight line and around obstacles. The subjects were timed and measured on the numbers of stumbles and falls that they had. The study showed that patients with Huntington's disease who used the 4-wheeled walker had more stability and less variability in gait. So I thought it was great that found this study and that Cindy already has a 4-wheeled walker, because that was, in this study, the best device for her. We also thought that the 4-wheeled walker, was an appropriate assistive device for Cindy because it provided her with a place to sit whenever she needed it. And that would help with her energy conservation and her endurance to be able to ambulate around the community and go to Costco like she wanted to do. As far as the therapeutic exercises, the chair push-ups were used to improve her upper extremity and core strength, which is important for functional mobility, and prepare Cindy for when her symptoms progress to the point where she has to be reliant on a wheelchair. This exercise was also used for fall education, and Cindy was instructed how to use a chair to get up off the floor safely and effectively if a fall was to occur. The wood chops were used to improve her upper extremity strength and core strength, as well as coordination and balance. The sit-to stands were used to improve her lower extremity strength, core strength, and improve her activity tolerance, getting up and down from a chair, as well as reducing her knee pain, which was one of her main goals that she wanted us to help her with. Cindy demonstrated a good understanding of the interventions performed and was able to recall and lead in the LSVT big sequence, which is great. Cindy did require quite a bit of encouragement and education on the importance of active participation in physical therapy to maintain her functional mobility and independence. She was limited at times due to feelings of sadness due to the progressive nature of Huntington's disease. And she did inform me that people tend to stare at her and judge her because of the way she moves. So we spent a lot of time just talking throughout the treatment session, just trying to figure out ways to help her. Overall, Cindy either maintained or had improvements based on the objective data. The objective tests that were used were the Tinetti Balance Assessment Tool, which showed that Cindy was still at a high fall risk, but she did have increase in her step length, which was great. We also did the tandem stance and the single leg stance. Cindy still required assistance to get into the tandem stance, but she wasn't able to hold the position. But she was able to perform a single leg balance and was able to hold 6 seconds on each leg. So that was really great, because in the beginning she was unable to do either of those. She improved in her dynamic gait index score, and depending on the activity, she was able to work and improve her balance with her choreic movements. And lastly, she improved in her lower extremity functional scale. She showed improvements with walking between rooms, squatting, and performing light household activities. So, the modifications that were made to progress her plan of care were to increase resistance and repetitions with therapeutic exercises, and the addition of obstacles and changes in surfaces when we were doing the 4-wheel walker training. An exercise that was given as part of her home exercise program were supine bridges, because they help improve her core strength as well as bed mobility, which is important as the disease progresses. So these are my take-home points. So Cindy, who was recently diagnosed with Huntington's disease, has shown some improvements in her functional mobility and balance despite the progressive nature of the disease. She continues to have choreic movements, slurred speech, and difficulty finding words, but is motivated to continue with physical therapy to help maintain her functional mobility and independence. It is important to know that physical therapy will not prevent further degeneration and will not change the outcome of Huntington's disease, but it will maximize the patient's functional mobility, safety, and well-being so they can participate and enjoy the remainder of their lives. The main take-home points that I want you to get out of this presentation are to be familiar with Huntington's disease, to know the symptoms, and to be able to be familiar with interventions if you do encounter a patient with Huntington's disease. Lastly, I wanted to include this card that I found for Cindy after she had expressed to me the sadness of how regarding the looks and judgments she was experiencing. So the card says, "I have Huntington's disease. If I appear to behave strangely, it is because I have HD. I may slur my words, appear to be distracted, or may have trouble walking. I know I am doing these things. I am aware what is going on. Please be patient. If I need help, please contact the person listed on the other side of this card. Thank you for understanding and caring." Thank you for listening to my presentation, and remember, don't judge a book by its cover.